So now guys, we are starting with one of the very important topics in ophthalmology, and that is ocular trauma. It is important because ocular trauma, it will always present as an emergency to you, yes. And also important for us as students because we usually get at least one question out of this topic in NEET exam and almost always also in the INI set exam, okay? So little small topic, around 20-30 questions total which can be asked, and you have a sure shot one question. It cannot get easier than that, okay? So what are we talking about here, everybody? We are first of all talking about mechanical ocular trauma, okay? Mechanical means due to an object. Now that object may have been blunt or that may have been sharp. So we can divide it further into two groups. The first group we are saying is blunt trauma, and the second group we are saying is penetrating trauma. The names itself are clear enough, yes or no? Penetrating, if a sharp object penetrates your eye, goes inside everybody, then we are talking about penetrating trauma, yes? But if you are struck by a blunt object, let's say this fist, everybody, nothing is going inside, but due to the severe force, everybody, you are having a closed globe injury, yes or no? If we think about forensic, everybody, we know there is open injuries and there are closed injuries. So when we are talking about blunt trauma, and that is what we are talking about first, everybody, we are talking about closed globe injuries. Or again, if I say refer to your forensic knowledge, we can call closed globe injury as contusion injury. Yes or no, everybody? So we are talking about contusion to the eye, closed globe, or blunt trauma to the eye. Now, what is the cause of blunt trauma? As I just explained to you, any blunt object, usually it is injury by fist. Medical colleges also, students fight a lot over some things. Yes, we all know over some things. Injury by fist, or if you have been an athlete, everybody, you are playing tennis, everybody, the tennis ball which travels at a speed of more than 100 kilometers per hour, it is coming and striking you on the eye, okay, everybody? So usually we say any of these two words. In certain cases, we also get fools who have just now married, opened a champagne cork, didn't know that the cork needs to be pointed away, they point the cork, tuck, and that is why they get a contusion or closed globe or blunt trauma to the eye. Okay, everybody? I hope we are pretty clear about this. Now, once we know that we have a case of blunt trauma, we are examining everybody. Yes, so we are seeing the signs. Don't ask me, sir, what are the symptoms? The symptoms you already know, it is trauma. There will be pain, there will be inflammation, there will be probably swelling if the eyelid is involved. We know all that, everybody. Yes. So what are we talking about? We are talking about the signs of blunt ocular trauma. Sign number 1. Okay. What we call as black eye. It is shown in all the movies, everybody. As soon as somebody punches you, your eye becomes black, everybody. Yes. That is basically nothing else but periocular hematoma. Yes or no? Around the eye there is hematoma. Number 2, everybody, if we talk about the conjunctival findings, usually you will have patients with subconjunctival hemorrhage. Okay. Subconjunctival hemorrhage is very common in trivial trauma. Trivial trauma like injury with nails, or let's say something like a pencil. Usually occurs in children, everybody. Yes, two children are playing something, the fingernail of a child gets struck in the other child's eye, everybody. Trivial trauma. It will only lead to a dark red spot, subconjunctival hemorrhage, nothing else, everybody. Yes. What we are concerned about is number 3. In the anterior chamber, on severe blunt trauma, you will see this hyphema. We have heard this word 3 or 4 times by now, I hope, if we are following the series of lectures, everybody. Yes. So what is hyphema, everybody? What is? Yes, hyphema is collection of blood in anterior chamber. Please remember, this is the most common sign of blunt ocular trauma. See, we are excluding the trivial trauma from this, everybody. We are talking about blunt trauma. As I said, the causes are fist injury, everybody, or an injury with a tennis ball or champagne cork or something like that. Something with force. We are not talking about mera haath lag gaya. Okay, everybody? Okay. So, most common sign of blunt ocular trauma. Now, everybody, let's see the photograph. If we have never, everybody. This is the photograph of hyphema. I hope all of you can see that only my superior part of pupil is visible. My inferior part of pupil is covered with blood. All this, everybody, is blood filled in AC, everybody. And this is your hyphema. Okay, everybody? Now, there is a grading scheme for hyphema. Not important, everybody, because usually we say hyphema resolves by itself. Now, my questions are two to you. Number one, why does it occur? Hyphema is collection of blood. So, what is the source of bleeding? Where is the bleeding occurring from? That's my simple question. Blood has to come from somewhere. If you are smart, you know the answer. How? This is my cornea, this is my iris. Anterior chamber, everybody, yes or no? This is where we are saying the blood is collecting. So that means the blood is collecting between two parts, cornea and iris. Cornea is avascular. So the bleeding has to come from, everybody, the iris. So source of bleeding has to be the blood supply of iris, which, if we remember, is circulus arteriosus major. A branch of, everybody, long posterior ciliary artery, which is a branch of posterior ciliary artery, which is a first branch of ophthalmic artery, which is a branch of internal carotid artery, everybody. Yes. And at last, everything will come from your heart, everybody. Dil se aata hai. Yes. Circulus arteriosus major. I hope there is no confusion about this. Now, what is the treatment? So in treatment, everybody, the first thing that we should know is, number one, we have to give steroids, topical steroids, to prevent rebleeding and obviously treat the associated inflammation. Okay. Secondly, everybody, at a lot of places, it is advocated that atropine be given to dilate the pupil, but its use is still controversial. Some clinicians like to use atropine. It helps in the aiding, or it aids in the absorption of blood, they say, and some don't, everybody. It is still controversial. Thirdly, please remember, if by 4 days no resorption occurs, then we have to perform paracentesis. That is, we have to withdraw that blood, everybody, or aspirate that blood, or we have to wash the anterior chamber. Okay. I hope we are clear about this. There should be no confusion about this here, everybody. Done? Now, after hyphema, everybody, let's move inside. Number 4. Let's look at the iris. When I look at the iris, I can see some signs. Number 1, the first sign I see is known as iridodonesis. What is iridodonesis? Iridodonesis means tremulous iris, or I can say trembling iris. Means you will see that the iris is like this, flapping. Why is it flapping, everybody? Try to understand. Assume that this part, everybody, this is my ciliary body, and this, everybody, this is my iris. This iris, everybody, is attached to the ciliary body here, everybody. Okay. Now, due to force, some of the attachments, root of iris, remember the anatomy, the thinnest part of the iris is root of iris. Some of the attachments of iris will break. Then due to the flow of the aqueous, everybody, this iris will keep on flapping like this. Okay, everybody, this iris will keep on flapping like this. And that is what is known as tremulous iris. Okay. Secondly, everybody, if you understand iridodonesis, you will also be able to understand iridodialysis. What is iridodialysis? Iridodialysis is detachment. Please remember, dialysis means detachment. When we do dialysis in kidney failure, everybody, we are removing the blood out of the body through a machine coming back. We are detaching the blood. Dialysis means detachment. Okay. Detachment of root of iris from ciliary body. That's why I said, if you understand everybody, iridodonesis, the force was weak, some of the attachments were broken. Now let's say in an area all the attachments are broken, so you will see that the iris has completely detached and you will be able to see the lens behind this area, everybody. You understand what I'm saying? Complete detachment of iris from the ciliary body in a particular area. That is iridodialysis. As soon as we see this photograph, I hope it becomes much more clear to us. What can you see, everybody? That in this part, everybody, okay, in this part, the infranasal part, we see that the iris has completely detached, everybody. The iris should have been here, everybody, but the iris has a detached. This is iridodialysis, everybody. I hope we understand this. Now, due to iridodialysis, what is the other sign you see? That is the important point here. See, normally the pupil should be circular. Yes or no? But here, what is the shape of the pupil? If I draw it, I can draw the letter D. Yes or no, everybody? So we are saying that there was iridodialysis, due to which the iris tissue lost its circularity. And that is why the pupil has also lost its circularity. At last, pupil is an aperture in the center of the iris tissue. Yes or no? So we say iridodialysis leads to D-shaped pupil. Am I clear to everybody? Iridodialysis leads to D-shaped pupil. That is the point I want to bring home. Leads to D-shaped pupil. If the MCQ is asked, what is the cause of D-shaped pupil? And both the options are given, blunt trauma as well as iridodialysis, don't mark blunt trauma. Again, I am saying blunt trauma cannot cause D-shaped pupil. Blunt trauma is causing the detachment, that is iridodialysis. And due to iridodialysis, the pupil is appearing D-shaped, everybody. So D-shaped pupil is due to iridodialysis. I hope very simple question answered for all of you. Okay. Now that's about iris here, everybody. Moving on, point number 5. Now we go behind the iris, we see the lens. Now what are the changes that occur in the lens due to trauma? If we have seen the video of lens, everybody, we already know that it causes a cataract. What is the name of the cataract? Rosette-shaped cataract. Yes or no? Rosette-shaped cataract, I hope we remember. If we don't, I'm writing it is again posterior subcapsular cataract. Okay. Secondly, again, we know, if we have read something called as ectopia lentis, I have clearly mentioned there in my shouting voice that the most common cause of ectopia lentis is blunt trauma, or I can call it subluxation of lens. Now, why will ectopia lentis or subluxation of lens occur? Very easy, everybody. We know that the lens is held in position by threads called as ciliary zonules. Due to the force, some of the zonules will break and the lens will move away from its position. What is the normal position of lens? Patellar fossa. But it will not be present in patellar fossa anymore. It will go up, down, left or right, somewhere, everybody. Okay. Now, third important sign in lens blunt trauma cases is something new to us. Vossius ring or Vossius ring. Okay. So what is Vossius ring? Vossius ring is imprint of myotic or meotic pupil on the anterior surface of lens. Imprint of myotic pupil on the anterior surface of lens. What do you mean by this? Everybody, let's try to understand. Let's say a ball is coming and hitting on my eye. So what is the direction of force that is applied? Anteroposterior. Yes, that means the whole eye, if I consider it a tomato, is getting pushed back. So I am squeezing it backwards, everybody. Yes. So my cornea is moving back. My iris is moving back. All the structures in my eye due to the force are moving back. So let's assume this is my pupil, everybody. This. My pupil, due to the force, my iris tissue, my pupil move back. And then there is the lens. So at some point of time, they go forcefully and they strike on the lens and then they come back. Okay, everybody? You understand the force? It will be like this. Go back, comes. Yes? Now iris, everybody, pupil or iris, everybody, it is a pigmented tissue. So when with force my pupil goes back, everybody, it is like stamping, everybody. It is going stamping and coming back. It is going stamping and coming back. And that stamp of the miotic pupil is visible, everybody. And that is what is known as osseous ring. If we see in the photograph, I hope we will be able to understand better, everybody. See this, everybody. There must have been a case of blunt trauma during which, everybody, there is this whole ring of pigmented iris tissue which is now formed on the anterior surface of lens, and that is what we call as osseous or osseous ring. Am I clear to everybody? No confusion, I hope, everybody. Yes or no? Done? Now, the last thing which can occur, everybody, is just like we saw in iris, phacodonesis, or we are saying tremulous lens, trembling lens. Okay, everybody. If there was soft trauma, then the lens will just be probably slightly shaking. If you ask the patient to look up, look down, you will see that the lens is not stable. It is shaking whenever you ask the patient to look anywhere because of weakened zonules. Am I clear to everybody? So these are the important changes that take place in the lens. Now moving on, everybody, to the posterior segment. Fundus signs of ocular trauma. Fundus sign number 1. Again, I hope we already know. That due to the fact that there is blunt trauma, there will be cherry red spot at macula. Yes or no, everybody? Cherry red spot at macula, the causes we have read in retina are cherry trees never grow tall in sand, mud and grime. T for trauma. Cherry trees, T for trauma, everybody. I hope we understand this. I hope there is no confusion in this whatsoever, everybody. Yes? Now, again, if I remember in detail, cherry red spot at macula was due to collection of fluid. Okay? Cherry red spot is due to collection of fluid, which in blunt trauma is known as Berlin's edema. Berlin's edema. Am I clear to everybody? Yes. So fluid collection will lead to cherry red spot. We know, we have read, we have explained in our retina macular diseases, everybody. Yes. But the fluid collection is known by a special name, and that is why it becomes an MCQ. Second point, the fundus appearance is known as commotio retinae. Cloudy gray appearance of fundus we see or retina we see, and that is known as commotio retinae. This is also due to edema of the retina. Okay. Next, everybody, optic nerve, traumatic optic neuropathy. This is usually self-limiting. Okay. The patient will regain vision after some time themselves. You don't need to do anything about it. Lastly, in rare cases, we get choroidal rupture. See, obviously, rupture can occur anywhere, but choroid can rupture here, everybody. And it presents in a bucket handle configuration. Choroidal rupture presents in a bucket handle configuration. And I'll show you the image for this, everybody. You will be able to see. So this is what a choroidal rupture looks like. You are able to see yellow color in this area. Why are you able to see yellow color, everybody? Because the choroid has ruptured, and this is the scleral show, everybody, which is occurring due to choroidal rupture. And if we understand, this is like a bucket handle, like we pick up the bucket, everybody, so we see a U-shaped handle here, everybody. Okay, I hope we understand that this is choroidal rupture. No confusion about this, I hope, everybody. Yes or no? Done. And that's the important fundus signs of a case of blunt ocular trauma. Okay, I've shown you the images, I've discussed the signs. These are very important, everybody. Okay. Apart from these important signs, everybody, in cases, we can also have globe rupture. Now, this is important. We are saying we are talking about blunt trauma. We are talking about closed globe injury. So majority of the cases are closed globe. But in certain cases, depending upon the amount of force, the direction of fall, blah, 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 we can have rupture of the globe. I'm not saying that there will be a laceration. I am saying there will be rupture of the globe due to blunt force only. Okay. So this globe rupture usually occurs due to a fall on an object like a knob. Okay. You fell sideways, you fell on a knob. The knob struck you here, applied force, such a force that there was a rupture, everybody. Okay. Now, the question that they ask you is, what is the site of rupture? So the site of rupture, please remember, is usually most commonly supranasal limbus near Schlem's canal. That is the site of rupture, everybody. I hope we are able to learn this simple fact, everybody. This will occur in very rare cases of blunt trauma, but nonetheless, yes, this can occur. Okay, everybody? And that's all about blunt ocular trauma. Now that we are done with blunt trauma, everybody, let us start with the second part, and that is penetrating trauma. In penetrating trauma, there are two important things that we need to remember. Penetrating trauma leads to a condition called as sympathetic ophthalmitis. Yes or no? Yes, we have heard of this. Short notes are asked in our MBBS first examinations. Yes, this has been discussed in detail in uveitis chapter. If you have followed the videos, you already know. If not, everybody, please remember, I have taught sympathetic ophthalmitis as a part of uveitis. Because at last, what is sympathetic ophthalmitis? It is pan-uveitis. Yes or no? Penetrating trauma leading to pan-uveitis, sympathetic ophthalmitis. The second is that the object which penetrated, everybody, has remained stuck inside. And that is intraocular foreign body, IOFB. And that is what we are discussing in short here, everybody. Intraocular foreign bodies.
Okay, everybody. What if a foreign body enters the eye inside, everybody? Yes. So, the first thing that we want to know is that the most common intraocular foreign body is iron or steel. Okay, everybody? Iron or steel chips. Am I clear? Now, what can be the problems when you encounter an intraocular foreign body? Because we are saying usually the iron body is iron, we need to know that an MRI is contraindicated. Instead, to see where the iron body has become penetrated, where is it now present, everybody, where is it now residing, we have to do a CT scan, investigation of choice. So please remember those two questions, that MRI is contraindicated, but CT scan is the investigation of choice. Iron foreign body will lead to siderosis bulbi. Okay. So all the changes that occur into the eye due to the iron deposition inside the eye are called siderosis bulbi. The first thing that you will see in siderosis bulbi is deposition of a rust ring. Rust colored ring, everybody, jung, yes, on anterior capsule of lens. Secondly, iron, which is releasing the rust, will make my iris darker. So I will have hyperpigmentation of iris. Thirdly, everybody, there will be secondary open angle glaucoma due to all the pigment, everybody, that will deposit on the trabecular meshwork and will block the trabecular meshwork. And lastly, we should know that to diagnose, we have to use the Prussian blue reaction. Prussian blue dye, everybody, that will stain all the iron deposits blue color. Prussian blue reaction. Am I clear, everybody? Done? Simple. So I'm just talking in simple terms, just putting a star and writing a one-word question. Ophthalmia nodosa. This is something which occurs due to caterpillar hair. Please remember a specific thing, caterpillar hair causing uveitis. So an intraocular caterpillar hair which causes uveitis gets to be known as ophthalmia nodosa. A lot of nodules are formed inside the eye. Right, guys? Done? That's it. Simple topic, intraocular foreign body, IOFB. Now, Now let's start with the third topic, everybody. A very interesting topic, an important topic, orbital trauma. Yes? Now, what if the tennis ball which was coming at 200 kilometers per hour did not cause trauma to the eye? Instead, it caused trauma here, here, or here. That means it caused orbital trauma on the bones. Yes? Orbit. Orbit is made up of 4 things. Roof, floor, lateral wall, medial wall. So, whenever there is orbital trauma, there will be fracture. So, the question that gets asked is, what is the most common fracture in orbital trauma? As I told you just now, there are 4 options: roof, floor, lateral wall, or medial wall. If you are saying medial wall, you are saying because you know the anatomy that medial wall is the thinnest. Even though medial wall is the thinnest, everybody, it is not the most common to fracture. The most common to fracture is the floor of orbit. Most common to fracture is the floor of orbit, and this is known as, everybody, blowout fracture. Blowout fracture of orbit. I hope you have come across this terminology. This is a short note in 3rd years, everybody, blowout fracture. So, blowout fracture, number 1, we know that it is floor of the orbit. Then what we should know are the clinical features. Number 1, let's do an X-ray. When we do an X-ray, we get the characteristic tear drop sign. Yes, tear drop sign. I hope you have seen a photograph. If not, then let's see the photograph, everybody. This is what a tear drop sign looks like. Can you tell me which orbit is showing this? Right or left orbit, everybody? Right orbit or left orbit, everybody? Yes, everybody, left orbit is showing us the teardrop sign. You will be able to see that due to the fracture of the floor of the orbit, the orbital contents are going down. Yes? So it looks as if the orbit is crying. So teardrop sign. Compared to the right orbit, the orbital floor is still intact. So there is no orbital contents which are going down through that fracture. Am I clear to everybody? Now, the second important clinical feature is infraorbital nerve anesthesia. Infraorbital nerve which travels on the floor of the orbit will obviously get anesthetized, will get paralyzed, or whatever you can call it. Number 3, double diplopia. Double diplopia. So all of us know what is the meaning of diplopia. Diplopia basically means what? Double vision. So what will double diplopia means? 4 vision. Yes or no? 4 images. Double diplopia 2 into 2. Yes or no? No. See, if I would have had to say 4 images, I would have called it polyopia, multiple image. Double diplopia means diplopia in up gaze when the patient looks up, and down gaze when the patient looks down, due to muscle entrapment of inferior oblique and inferior rectus by fractured bone pieces. Okay? Are you able to comprehend what I am saying? Yes? Inferior rectus travels on the floor of the orbit and gets inserted inferiorly. Inferior oblique also passes the floor of the orbit and gets inserted inferiorly on the eye. So when there is floor of orbit fracture, some of the bone fragments will not let the inferior rectus and inferior oblique carry out their action. They will restrict, focus on the word, they will restrict the action of both these muscles. Inferior oblique causes elevation. So when you look up, you won't be able to look up gaze diplopia. Inferior rectus causes depression, down gaze diplopia. So thus it is an example of, if you understand, restrictive squint. Pieces of bone fragment restricting the action of the 2 muscles, everybody, and thus causing diplopia. Restrictive squint or paralytic squint, 2 types of incomitant squint. Restrictive. I hope you understand this. Right, guys? Done. These are the simple clinical features of a case of blowout fracture. I hope you are able to understand this. I hope you have been able to comprehend the photograph of teardrop sign. Now, we said that the most common fracture is floor of orbit. Okay. But can fracture of roof of orbit occur? Yes, it can occur, no? So fracture of roof of orbit presents with the classic sign that all of us have heard of, known as raccoon eyes or panda eyes. Forensic medicine, we must have come across the word raccoon eyes. Raccoon eyes are seen in fracture of the floor of the skull. Roof of orbit is the same as the base of skull or floor of skull. Yes, everybody? Now, if you have seen Kung Fu Panda, you understand black eyes both bilaterally, everybody. I will show you an actual photograph of a patient. So, she's a patient of road traffic accident. Okay? And as you can see, both the eyes are like Kung Fu Panda or raccoon eyes, everybody. Okay, everybody? So, this is an actual photograph. I hope you are able to comprehend it. Right, guys? Done? Now, that's all about my topic, orbital trauma. Simple, short, sweet, 5 or 6 questions, 2 images. Now, to end the chapter on trauma, everybody, let's do a very simple topic, chemical injuries. Questions have never been asked, if I can say so, in the past 10 years. But yes, they can be asked. Very simple. I'll just list 4 or 5 points. You should just be able to remember that. Right? Now, chemical injuries can either be due to alkalis or they can be due to acids. Right? Alkalis. Alkalis cause necrosis of the tissue. Acids cause coagulation of the tissue. Due to necrosis, alkalis will penetrate deeper. See, they are destroying the tissue, necrotizing the tissue, and thus moving deeper. Yes, penetrating deeper. Whereas acids, because they are coagulating the tissue, they are actually forming a barrier for their own penetration. So they do not penetrate at all. I understand that if you understand these simple words, you understand that alkalis for my eye are more dangerous. Yes? Now, apart from this, please remember that Dua's classification and Roper Hall classification, both these classification systems are used to grade ocular surface burns. I'm not going into the grading scheme. I'm just mentioning the names, everybody, of the classification schemes. Okay, done? No confusion? Now, if chemical injury has taken place, see, it is very rare to encounter a severe chemical injury. Usually you will get a very superficial, very minute. Somebody will say that I put, let's say, some makeup thing in my eye, or these days hand sanitizer entered the eye. So they are never severe injuries. Okay. So as a management, mostly the only thing you need to do is copious irrigation of eye using balanced salt solution or ringer lactate by double eversion of eyelid. Double eversion, everybody. See, if you wash your eye, the water is only, if you just, splashing your eye like this at home, water is just touching probably some part of the cornea, that's all. You need to be able to wash into the fornices, everybody, completely. So you need to evert, everybody, okay? You need to turn it twice, everybody, so that you can reach all the corners. Anything that gets deposited in the corners. So you have to give it a copious, thorough wash. That's the main important thing. Am I crystal clear about this? Yes? Then, after you have done copious irrigation, obviously you should give some treatment. So you should give topical antibiotics to prevent any superimposed secondary infection. You should give atropine in case the penetration has occurred up to the uvea, so to relieve the ciliary spasm. You should give lubricating eye drops, because almost always you will see that the corneal epithelium has been damaged slightly. So you need to lubricate for it to help and grow back. Yes? Then, importantly, you should give topical sodium citrate drops. Sodium citrate will prevent further proteolytic activity.